everyone. Today I'm excited to share our latest research on the differences and complications between staged and combined DMEK and cataract surgery. As I delve into our research, we will walk through the following sections. Before we jump into the specifics of the surgeries, let's familiarize ourselves with the anatomy of the eye. From the front to the back, the notable structures are the cornea, iris, pupil, lens, retina, and sclera. We'll focus on the cornea and the lens. So the cornea is made up of 5 layers. The Descemet's membrane is a thin but strong layer of tissue within the cornea, and surgeries such as the Descemet's membrane endothelial keratoplasty, or DMEK, operate on this part. The lens is located behind the iris, and this structure bends light, just like the glasses lenses that you could wear, and focuses light onto your retina at the back. Cataract surgery specifically targets the lens. So DMEK is a procedure designed to treat certain corneal diseases. It involves replacing the Descemet's membrane and the endothelium with donor tissue called a graft. This leaves the rest of the patient's cornea intact. This procedure is beneficial for conditions like Fuchs dystrophy or other endothelial disorders. On the other hand, cataract surgery is one of the most commonly performed surgeries worldwide. As we age, the lens can become cloudy, leading to blurred vision or glare. Cataract surgery involves removing this cloudy lens and replacing it with an artificial intraocular lens. These surgeries can be combined, which means they're performed in one operation, or staged, which means that they're performed in separate operations. The combined approach is more cost-effective and allows the patient to see more clearly and has similar clinical outcomes as staged surgeries. However, the combined approach may have a higher incidence of surgical complications. Therefore, we aim to compare the clinical outcomes when a patient undergoes staged versus combined DMEK and cataract surgeries. Understanding this will guide surgeons in deciding the best surgical path for their patients. Our study involved data from 20 eyes in 14 patients who underwent the DMEK and cataract procedures separately. It also involves 24 eyes in 17 patients who underwent a combined DMEK and cataract procedure. To measure surgical outcomes, 3 measures of interest were taken. The first is a patient's visual acuity, or VA, which is how well they see. The second is intraocular pressure, or IOP, which is the pressure inside the eye in millimeters of mercury. And the third is any surgical complications, such as the failure of the DMEK graft to adhere to the eye and needing a second surgery, or signs of inflammation, seeing floaters or glares, or an allergic response. VA, IOP, and complications were compared between 1 week, 2 weeks, 3 months, and 6 months post-operation. Statistical significance was calculated using Fisher's exact test. In terms of our results for mean VA at each of the 4 different time points for the 2 groups of the study, there was no statistically significant difference in VA at 1 week, 2 weeks, 3 months, or 6 months post-operation. In terms of the mean IOP for the 2 groups at the 4 time points, the combined DMEK and cataract surgery had lower IOP 1 week post-operation, with a p of 0.02. However, there was no statistically significant difference in IOP at 2 weeks, 3 months, or 6 months post-operation. The most prevalent complications were high IOP, which is higher than 22 millimeters of mercury, and incomplete adherence of the graft, requiring rebubbling, which is when a bubble is injected into the eye to help the graft adhere. There was no statistically significant difference between any single complications or for overall number of complications. In conclusion, combined and staged DMEK and cataract procedures demonstrated similar clinical outcomes in VA, IOP, and complications post-op. Combined DMEK and cataract surgeries resulted in a lower IOP 1 week post-op, but was not significantly different beyond the first week. Future research should employ randomized controlled trials with a broader sample of eyes to discern whether combined is comparable or superior to staged DMEK and cataract surgery. Data from continuing such studies will impact surgical choice based on clinical outcomes, time, and cost benefits, as well as improve patient-centered care. Thank you so much for viewing this presentation, and don't hesitate to reach out via email.